to the cloud. I am turning this over to Dr. James Frame. He's our lead medical director in charge of several states, including Texas. And Dr. Frame does a wonderful job of these roundtables for those of you guys who haven't been here before. It's a perfect opportunity for you to get to talk to him and get to know him, and him to get to know a little bit about you. So have a little bit of fun, and I'm going to mute myself. If at any time you'd like to ask a question, you can either unmute your microphone and talk to him. That should work just fine. If you don't have a microphone, then you can type into the chat box.
Hey, Jane, walk me through this one more time. How do I get my PowerPoint to show up?
Scroll down to the bottom or push that to the gray bar at the bottom of that box and click Share Screen.
Okay. And click the whiteboard. Where do I click Desktop?
Desktop. That's it.
And let me know if you see it.
Yes, sir, we sure do.
Wow. We did that in less than 20 steps. All right, good deal.
Yeah, there you go. I'm going to turn it over to you, sir.
All right, thank you. All right, well, as my good friend and partner Jane just told you, I'm your medical director. My name is Jim Frame, and I'm pleased to bring to you a two-part series today about respiratory emergencies. The presentation today will focus around chronic obstructive pulmonary disease and its two disease processes, both emphysema as well as chronic bronchitis. And then asthma. We'll conclude today's discussion at the end of asthma, and then next week we will pick up with status asthmaticus and move towards toxic inhalations and other items of interest when it comes to respiratory emergencies. In any event, let's get started. On the National Registry exam, respiratory emergencies constitutes about anywhere from 10 to 17% of the exam. Airway management, respiratory emergencies, and such are all kind of clumped together, but the questions themselves are going to be about 10%. So if you get to question 80 or 90, you've probably already answered about 8 or 9 questions pertaining to respiratory emergencies. Should you have to go a little bit longer on your test and hit question 100 to 120, it'll behoove you at that time to know your respiratory stuff backwards and forwards. And remember, the National Registry is what we call adaptive testing. If you get 2 or 3 questions correct, then the 4th question that pops up is going to be harder, the 5th one even harder yet, until it finally figures out where you are getting them wrong. And then it backtracks down to a lower level. And hopefully you can maintain that, that one below the difficult question. Adaptive testing is kind of something that's new. It's spreading the country like wildfire. Everybody's using it now, including real estate agents. They're getting into adaptive testing as well. The military has used it for quite a number of years, and it's worked out pretty well, especially when you're training pilots, navigators, and such. Haven't seen it yet in the medical schools. There's still, as a matter of fact, pretty much on paper and pencil and bubble sheets and such, but I assume that that'll probably be making its way into their curriculums here pretty soon. Law school is a completely different format, so those are all essay questions, and you'll see something different there. But for the purposes of the National Registry, the computerized adaptive testing is good from the standpoint that it establishes a baseline for you right away, and then kind of peels off from there to see exactly where your knowledge base ends. We also use this conglomerate or cohort of students every year that take the test. We use that breaking off point to see what questions are good for next year, what aren't. And it gives us a pretty good idea how well the curriculums are being taught as well. So if 1,000 people take it and 900 people miss a certain question, well, then we got to redefine the objective, or we're going to have to find a better way to present it, or it's just that difficult of a question. And again, it gives us a pretty good idea of where the students are heading, both as an individual yourselves as well as an entire country. So In any event, computerized adaptive testing is here to stay. Embrace the horror. It's not going anywhere. All right, so let's open this all up to chronic obstructive pulmonary disease. We have 3 types of COPD, actually 2. It's chronic bronchitis and emphysema. Asthma is not so much a chronic obstructive pulmonary disease in that it's not an anatomical issue, it's more of a functional issue. Asthmatics at autopsy have normal lungs, as long as they didn't die of an asthma attack. Yet emphysema patients, as soon as you open up the chest, you can tell they've had emphysema. The lungs are black from all the tar and carcinogens that they've inhaled their whole life through cigarettes. When you squeeze the lungs, black fluid comes out. The patients are barrel chested and such. And so that's a structural abnormality caused by the destruction of the lung tissue by cigarette smoke. Chronic bronchitis is chronic infections that keep occurring within the lung as well. And you get a chronic buildup of mucus quite a bit. IgA is the antibody that protects the lungs and the gastrointestinal tract. And those immunoglobulins have been pretty much overrun with chronic bronchitis. They're no longer effective, whether that was due to cigarette smoke or too many infectious agents over a long period of time. Chronic bronchitis is, again, coughing, congestion, productive cough and such for 3 months out of the year for 3 consecutive years. That's not on the test, but a pretty good idea of what chronic bronchitis constitutes. All right, so let's start digging into it. As you get into your paramedicine, you'll get on the scene of patients who have had exacerbations of COPD, in other words, an emphysema. And what you should know about it is that the alveoli are directly affected. The bronchioles is the only part of the bronchial tree, and this you will have to know for your exam. The bronchioles are the only part of the bronchial tree that has muscle surrounding it. And so this is where all the muscle constriction and muscle dilation occurs, bronchial constriction, bronchial dilation. And so when you get allergic reactions, when you get histamine to hit those muscles, it causes those bronchioles to constrict. When you give a beta agonist, a drug which is designed to dilate the bronchioles, what it does is it sends its drug to the muscle relaxes, the bronchioles open up, patient breathes a little easier. Those bronchioles, and there's well over 100 million of them in the lungs, each bronchiole having about 5 to 7 alveoli attached to it. And there's 700 million alveoli in each lung. So as you can imagine, the numbers here are pretty big, and it takes a long time to destroy these. But cigarette smokers are very patient people. They insist on smoking for 20, 30, 40 years, and over a period of time, they finally achieve their end goal, which is to commit suicide by cigarettes, by destroying their lungs and making their lives and everybody around them miserable. And that is the end game for emphysemic patients. So during that time, though, they develop all kinds of stuff, including infections of the lungs, pneumonias. And then with the chronic obstructive pulmonary disease, they retain CO2. Their chests become very big, very barrel-chested, if you will. And then ultimately, a pneumonia, viral infection, or some sort of allergen triggers these COPD episodes, and they ultimately come into your EMS system, acutely short of breath, difficulty breathing, need transport to the hospital. The anatomical destruction that occurs, you should know it's destruction of alveolar walls below the bronchioles. That's a quote right out of one of the tests. It decreases the area available for exchange of oxygen with carbon dioxide, and of course it decreases the surface area. Instead of having a nice round alveoli in 3 dimensions, it crinkles it down, causes it to get stiff and collapses, and subsequently you don't have much of a surface area there to exchange oxygen and carbon dioxide. Now, as a person develops their chronic obstructive pulmonary disease, as they continue on their goal to destroy their lungs, the lungs start to lose elasticity. They could take a deep breath in, but the lung cannot recoil. It's lost its elasticity. Therefore, the air is trapped and it really can't get out. You almost have to go come in behind these people and squeeze their chest. Well, it's not as simple as that, but that's functionally is what's going on, is that they inhale, they can't exhale. So subsequently, this oxygen carbon dioxide exchange occurs in the alveoli. Carbon dioxide goes in the alveoli, the oxygen goes in the bloodstream, but then the next breath or the next 2 breaths or the next 10,000 breaths that they take over a period of a day or so, and then the next million breaths that they take over a period of a year and such, it becomes much more difficult to move air out of the lung. And therefore, the carbon dioxide builds up within the alveoli and then builds up within the bloodstream. Now, you should know in the brain, that our primary drive, our primary respiratory drive, is that when the thalamus, hypothalamus, and the respiratory centers in the brainstem, when they determine that the carbon dioxide level is getting too high, it sends a nerve impulse to the phrenic nerves, the diaphragms, and you initiate a breath, a deep breath. Suck the oxygen in, blow out the carbon dioxide. Now the carbon dioxide levels come down to about normal, a little below normal, and the CO2 center that's in your brainstem now waits for the CO2 to rise again. And then we take another deep breath. And we do that between 12 and 20 times a minute during periods of physical exertion, excitation, and all the other panics that happen out there, including disease. That respiratory rate can get upwards of 30, 40, 50 a minute. And babies, more than that, 60 or 70 a minute. So that kind of rapid exchange is pretty vital, understanding that the oxygen CO2 exchange occurring within a perfect alveoli, the trigger for that respiration is a CO2 drive, carbon dioxide drive. Now, what happens to the emphysemic patient? Carbon dioxide builds up in the bloodstream and it gets worse and worse and worse. And it gets higher and higher and higher to the point where that CO2 drive is completely wiped out. It can no longer function. And as a result of that, let me get back to that for a second. As a result of that, you're unable to take any more breaths, but here comes your backup system. And that's the low oxygen drive. The low oxygen drive, which is right there in the brainstem as well, waits for the oxygen level to drop down. And when it gets to a certain level, then it initiates a breath. Well, as you can see, it's not as efficient as detecting carbon dioxide, because carbon dioxide is an acid, and it's easy in the body with acid-base balance and all the baroreceptors and chemoreceptors throughout the entire body, that you can initiate a breath with your CO2 start to climb. In other words, when the acid starts to get a little bit too high, you get the next breath. Well, with low oxygen, you have to wait for the oxygen level to drop down, and then it stimulates the next breath. And that next breath, you can see a person actually kind of gasp a little bit, kind of a guppy breathing a little bit. And that's your backup system. Now, imagine if you're at home and your emphysemic patient is sitting there, and you put out a nasal cannula and you turn him up to 3, 4, 5 liters, or you put him on a non-rebreather. What have you done to the oxygen drive? You've wiped that out too. In other words, by giving them too much oxygen, the low O2 center does not sense low O2, and the patient doesn't breathe anymore. What does that mean? It means that the already high carbon dioxide level that's present is going to get even higher. What happens when you have too much CO2 in your bloodstream? You get acidotic, which can throw you into ventricular arrhythmias, but more importantly, CO2 is a very powerful narcotic when it's in real high doses within the bloodstream. So if you say a normal PCO2 is between 35 and 45, and you're sitting at 70, 75, 80, or even higher, it acts as a narcotic. And subsequently, your mental status becomes altered. You stagger, you do have an intoxicated appearance, you slur your speech, you can't think, you can't do anything straight. And the next thing you know, you go into respiratory arrest and you pass away. So Subsequently, when we meet up with our emphysemic patients, we have to be very careful about where we start them and how we start them. Nasal cannula 2 liters is what most people are on at home. Sometimes they go up to 2.5 or 3 liters. We'll talk about treatment here in a few minutes. So when you assess these patients, you see the following. You see that they have lost a lot of weight during their years of trying to achieve their goal of destroying their lungs with cigarette smoke. You know that they can get short of breath and difficulty breathing just walking across a room. I mean, 700 million alveoli in each lung, and you've managed to destroy 500 million of the 700 million. 200 million on each side is not enough to live on. If I were to take one lung out of your body right away, right now, boom, that's the end of it. Tension, pneumothorax. What it is, if I took it out of play or threw a pulmonary embolism in it, there's a good chance that the patient would not make it unless they were in great physical shape, like a young person. You just can't cut off that quickly. But as you know, with the human body, if you do something slowly enough, you can acclimate to it. You can tolerate it. You can become used to it, whatever euphemisms you want to use. Subsequently, as you slowly destroy your lungs over 20 years or so, you learn to live on 200 million alveoli on each side of your lung. However, it's barely enough for you to get to your car and back. You certainly can't walk them all without sitting down at benches. And next time you walk through them all, look at the people who are sitting on the benches. And every once in a while, you'll catch a COPD or sitting there just out of breath. You won't find them doing much in the way of exercise. You're not going to find them at health clubs and such. They've already thrown in the towel and all that. So subsequently, you'll find these people to be very thin. They'll also have cough. And if you live with an emphysemic patient, or if one of your relatives or grandparents are emphysemic patients, you'll know that when they get up in the morning, for the first 10 or 15 minutes, they're just coughing up black, brown sputum all morning. And they go into the bathroom and you hear them coughing, gagging, and then finally they come downstairs, have their first cup of coffee, and they have to have their cigarette right away. One breath, one inhalation of nicotine paralyzes the cilia, the little hairs that line the lung, and all the way down to the alveoli, not including the alveoli, but all the way down to the bronchioles. And what they do is, by reverse motility, they take whatever is not supposed to be in there and they sweep it back up, ciliary motion, and they move it from the lower lungs all the way up into the trachea, where you then cough and spit it out. If you take a puff of nicotine and nicotine hits the ciliary hairs, it paralyzes them for 24 hours. So you can imagine that's just one puff. Now, each emphysemic patient out there between a half a pack and 2 packs a day smoker have their ciliary hairs in constant state of paralysis. So you pretty much lost that most important part of your lung defenses. So when you go to sleep and wake up the next morning, all that sputum is pooled and some of your cilia have come back a little bit, it's starting to cough. It's starting to move stuff into the main stem bronchioles. And that's what's stimulating the cough reflex. And that's why these patients start coughing a lot. And if they were to lay off smoking for 2, 3, 4 months, they'd be coughing every single morning, getting everything out that they've smoked for the last 20 years. Now, as a result of all that air trapping that we talked about earlier, where the lungs expand, but because they've lost their elasticity, they can't contract back down again, the patient develops what they call a barrel chest. You see these guys walking around, they've got quite thin bodies, but yet their chests look like that of a muscle builder. Unless you take their shirt off, then you figure out their skin and bone. But the lung is permanently inflated and then hyperinflated to the point where it hypertrophies, in other words, makes thicker the rib intercostal muscles, and it actually pushes out the ribs and the sternum to the point where it looks like they're wearing a barrel around their upper torso. And of course, they're always breathing a little bit more rapidly than the average person out there. Their respiratory rates can be somewhere between 24 and 30 a minute on a good day. Now, these guys, these emphysemic patients, are known as pink puffers, as opposed to chronic bronchitis, which are blue bloaters. A pink puffer also has clubbing of their fingers, The reason why they club their fingers, in other words, as you hold your hand up and you're looking at the fingertips, there's a nice round finger. Well, when you club them, it's like cutting them straight off, right across. And then you got these square peg-looking kind of fingers or club fingers. And the reason why they do that is because the most distal aspects of any vascular system is going to be the toes and the fingers, the tip of the nose, the earlobes. Those are the most distal portions. So they're going to be greatly affected by any even minimal drops in oxygen levels. And so when a person becomes hypoxic, when they're on hypoxic drive, you're going to find that until the brain gets sensation or gets the signal that the oxygen's dropping too low, that blood is already at the fingertips. And over a period of years, the patient stunts their ability to remodel and remold their fingertips. And the same thing with their toes. And as a result, they get clubbing of their fingers. They also get pursed lip breathing. They have prolonged expiration, but you'll find that when you're real short of breath, if you purse your lips and blow with some back pressure, it feels a little bit easier. It's a little easier to breathe when you purse your lips and you blow out when you're really short of breath. And you'll find that the emphysemic patients do this quite a bit. Now, wheezing or rhonchi is that real deep adventitial type sounds that you hear on the lungs and the bases mostly, where it sounds like there's a lot of rattle down there. Not stridor, which is upper airway around the vocal cord, but lower airway. You hear this real deep ronchorous type sounds, rattling sounds. That's rhonchi they're talking about. Of course, wheezing, you already know, could be inspiratory or expiratory. And it's important for you when you listen to patients' lungs and then report it to the hospital for us, any patient that you do lung assessment on. If the wheezing occurs during inspiration, then you probably got some sort of mucus buildup or viral or bacterial infection. Pneumonia is very common. If it occurs on exhalation, expiratory wheezing, then that's usually classically associated with asthma or COPD. Okay, so that's kind of the pathophysiology and the signs and symptoms of emphysema. Now, how does that relate to the National Registry? National Registry is good for 1 or 2 scenarios where they have some of these characteristics already on there. So they're going to say, well, you know, you have this page, you arrive on the scene of a 76-year-old male who's at home. He tells you that he's been short of breath with some difficulty breathing, but he seems to be very confused. His heart rate's 117, his respiratory rate's 32, his pulse oximetry is 85%. You notice that he's got a barrel chest. Okay, he's got some clubbing to his fingers. So these are all giveaways. On auscultation, you hear end expiratory wheezing, but very diminished. Breath sounds are very, very diminished. What would be the appropriate treatment plan? So what you have to do is look at that question, put it in the context of the first 4 slides that we just shown here right now, say, aha, that person is COPD, and even though nobody's here to give me the history, I surmise that this is probably a COPD patient. So what would be the next treatment? And you'd start rolling into your protocols at that point. So that's where emphysema, the first 4 slides will fit in, is how to identify that in a scenario. Now, chronic bronchitis patients, I'm only going to talk to you about chronic bronchitis for a few moments just to help you in the field. But as far as the National Registry exam is concerned, I haven't seen a chronic bronchitis scenario. I don't think I've ever seen one. I've been reading these questions for some 10 years now. But let's go over chronic bronchitis. You can write it down as notes or just listen. I can assure you it's not going to be on the exam. But you have an increase in mucus production now. You don't have that stimulation to the muscle where the muscle constricts and therefore the bronchiole constricts and the alveoli get destroyed as a result of loss of elasticity and constant tar and nicotine down there. In this particular case, you get infections down there which keep producing mucus. And then you get a large amount of sputum. These are people who really come up with a lot. They cough and they gag, and it sounds like they're hacking up their entire lung. And turns out they come up with a large amount of sputum and such, and they're constantly spitting it out. It's pretty disgusting. But bottom line is they're at least trying to get the infection out. Problem with chronic bronchitis is that they get an infection. There's sometimes chlamydia, or if they work around poultry or chickens a lot, such like that, you get the chlamydia or psittacosis. And then the people that work around other type of fauna, birds, animals, and such like that can get the various other types. But in the United States here, the chlamydia trachomatis, which gets in the eye, and then the type of chlamydia that occurs with lamb, sheep, and poultry and such like that, those can develop chronic bronchitis pretty easily. You usually find those folks obviously out on a farm. Now, the diffusion of their oxygen and carbon dioxide is a little bit shifted towards, again, a buildup of carbon dioxide. Even though the alveolar walls themselves are intact, the problem is you're having air being trapped in the middle airways and such, and it can't quite get down there, and the carbon dioxide can't quite get out. And so you get a hypercarbia, in other words, a buildup of carbon dioxide. These patients generally tend to be very overweight. They're called blue bloaters for a reason, because they're always walking around looking like they're short of breath and they're a little on the cyanotic side. You'll hear rhonchi all the time with these guys. And most importantly, just like with the emphysemic patient, these patients can get in the right side congestive heart failure pretty easily, probably more so because of their weight situation. And then, of course, these are the guys that have 2 and 3 plus pitting edema in their lower extremities as well. This is just, you know, peripheral edema secondary to right heart failure. They can't get the preload up into their heart, and since edema is mostly gravity dependent, the legs get most of the edema. So let's go to, I'm not sure why that sound effect is there, I apologize for that, but let's talk about management of chronic obstructive pulmonary disease. You got to treat the hypoxemia. Don't ever deny oxygen to somebody who needs it. Look, if they're running 88, 89, 90%, up to 92%, you know, you can touch them with 2 liters O2 nasal cannula and let them sit between 88 and 92%. That's probably where they live most of the time anyway. And subsequently, if a person's dropped down to 80%, don't sit there and say, all right, here's a little cannula. We're going to try and get you up to, you know, 2 liters, but that's it, because I'm going to wipe out your low O2 drive. That's all nonsense, total nonsense. Never deny anybody oxygen who needs it. So again, if the COPD is really running into a rough time, you're going to be in for a rough time, because these patients will breathe, and then all of a sudden stop breathing, and you've turned a COPD into a full cardiac arrest. So give them oxygen. Just be careful. Now, you want to reverse bronchoconstriction with albuterol and Atrovent. What we do is we take those little vials that you got, you throw 3 of them into an aerosol, screw it on tight, put the oxygen bottle on 6 liters, put it in their mouth or put it in their mask and let them breathe in for 1 full hour. At 6 liters, 3 doses of this stuff in there should last about an hour, 5 to 6 liters. Don't throw it up to 10 liters. All you're going to do is shower the stuff into their nose. You need to create a vapor. That's why we say 5 to 6 liters. And 3 doses should be more than enough time to get you to any emergency room. Piece of cake. 3 into it, turn it on, you're done. And you want to keep their oxygen saturation around 92%. That's about it, 92%, a little bit more. Don't strive for 100. COPDers probably haven't been 100 in probably 10 years before they finally get to the point where they need to be calling you on a routine basis, mostly in the middle of the night when you're trying to get sleep. And then, of course, you're monitoring for cardiac dysrhythmias. Now, in addition to albuterol aerosols, some of you, not all of you, but some of you may be in EMS systems where they carry steroids. And subsequently, citomedrol, 125 milligrams IV push for adults is the standard of care. The steroids and the albuterol with the Atrovent are going to be on your national registry exam. Guaranteed 100%. I've seen it many, many times. It's going to be aerosols. It's going to be the salumedrol. You're going to see it in different ways. Methylprednisolone is the other word for salumedrol. For the most part, National Registry exams, just like medical boards and such like that, cannot endorse a particular product. So they use the generic name. Methylprednisolone is what you're going to be looking for. And that steroid is going to be decreasing mucus production. It has no way has to do with any bronchodilation or bronchoconstriction. There's two things that happen with the COPD. They get bronchoconstriction, and then the mucus starts building up because of infection or whatever it is that's causing the mucus and sputum to be produced. So you want to give the albuterol with the Atrovent to open up the airway, and then you want the steroids to decrease or eliminate the mucus production so you can open up the airway even more. Imagine a tube that you squeeze your hand around. That's constriction. Imagine that same tube where you coat the inside or clog up the inside with whatever it is you like to clog things up with. You know, cotton ball, hard cast hair, you know, whatever clogs up your drains at home, pretty much clog up the same thing in the lungs as well. And subsequently, you get even less and less air through. So the purpose of the steroids is to decrease mucus production. So we use beta agonists, beta 2 selectives, obviously the albuterol, the Proventil, the Ventolin. Back in the days, when I was a paramedic back in the 70s, we used Isoprel. We didn't have anything called albuterol, albuterol, anything like that. So we'd use Isoprel, which is a pure beta agonist. But unfortunately, it was a non-selective beta agonist. So what happens when you stimulate the beta 1 cells? You get tachycardia. What happens when you stimulate beta 2? You get bronchodilation. Unfortunately, as soon as these patients got done with what they call an IPPB treatment, or what we called them back then, which is now a breathing treatment. Back then, you'd get a patient that was wildly tachycardic. Give that stuff to a 70-year-old with heart disease, and you got yourself a cardiac arrest going. So there was never really any really great treatments up until about the mid-'80s when albuterol came out. When that came out as a selective beta 2, and some of its other chemical names, when that came out as a selective beta 2 where it wouldn't hit the heart as hard as the Isoprel did, but it would also be much more effective in dilating the bronchioles. So that's the history behind the albuterol. Bronchosol, Alupent, those are some of the older ones that started to develop after Isoprel came out and started really killing people. So management of COPD for purposes of your exam is going to be albuterol aerosol with Atrovent or apatropium chloride, which is the anticholinergic part of the ANA treatment, the Atrovent. The objective being that, once again, is to dry up secretions, and Atrovent does a wonderful job doing that as well. All right, anybody have any questions? I'm looking down at the chat here, and I'm not seeing, let's see if anybody's saying. Ashley, sorry you're late. Yeah, things happen, no problem. Will, okay. Does anybody have any questions? I want to make sure I still got everybody here. It's kind of the halfway point. So just type your message that you're still here, or just shout out on the over your microphone. Yeah. Elise, Scott, good. Ashley, good. Seth, great. Well, good. Missing, good. All right, everybody's still here. Good deal. So luck out once in a while here. All right, I just set you out. Okay. We're going to switch gears now to asthma. I redid the slides on asthma because I just had a chance to review a paramedic test given by the National Registry, and we are woefully in a crisis situation within the country with asthma. Subsequently, we still have unnecessary deaths, especially in children, which occur as a result of asthma. About 200 children die each year, 3,400 adults die each year. And that does not include the people who you successfully resuscitate and are brain damaged, and they get to live in nursing homes and pediatric care for the rest of their lives because they don't have much of a brain left. So those are not included on the statistics, but you could probably go with doubling each one of those numbers. When I get these patients in the emergency department and I get them resuscitated, a family will come up to you and say, thank you for bringing him back. And the answer is, well, let's see what we got when we wake him up, because he was down quite a long time. So, and then of course, the group of folks that are over 45, they're three times more likely to die as a result of it. Why? Reserve capacity, the shape that they're in, comorbid conditions, you know, asthma with COPD. Oh boy, there's a good one. Asthma with heart problems. Ouch, that hurts too. So asthma with diabetes, the worst, asthma with hypertension. These are all comorbidities that are very significant. And so when you catch like the influenza bug that ran around this country just recently and killed, you know, over tens of thousands of people, either directly or indirectly, one of the biggest sufferers are COPD patients and asthma patients. Now, let's talk about this. This was on the test. I was very curious, which is why I'm going to include both of these rules. Number one reason for death: the patient or the family underestimates the severity of the attack. You could be the asthmatic sitting there going, I took my inhaler, I'm okay. Yeah, I'm a little short of breath, I'm not bad. You cough a little bit, you're like, well, I'm not wheezing a whole heck of a lot. And then you go about your day and all of a sudden you hit that point where you're way too much under. So then an asthmatic would typically go lay down, take a hit on their inhaler, they go to sleep, and they wake up dead. That's the problem with the asthma, is that you go off the cliff real quick with the asthma. So the number one cause of death is that the patient underestimates the severity of their attack. The number two reason for death, and you're going to be very dismayed to hear this, is that paramedics and doctors underestimate the severity of their attack. Patient comes in wheezing, yeah, I'm short of breath, difficult to breathe, I'm speaking 2 to 3 words per sentence, 4 or 5 words per sentence. I look at the pulse oximetry, he's all right, he's got 98%, he's fine. Well, he's compensating all the way to the point where he can't compensate. And as soon as he no longer compensates, and you turn around and you go, oh my God, you know, did he go down the tubes quick? No, actually he's been going down tubes for a while. You just failed to miss the aspect of the asthma, which says I'll build up my CO2 all the way up to the point where I get narcotic, and then I drop my respiratory drive, I become hypoxic, then I die. Which is why end-tidal CO2 on these patients is very important if you're going to assess their risk and their prognosis. I usually just pop a end-tidal CO2 cannula on them and get that EtCO2, and I look at it on the monitor. If I see it's 50, 55 already, hell, I'm hitting these people with continuous albuterol aerosols, giving them methylprednisolone 125 IV push, and I'm standing by with an ET tube in my hand, ready to go on these guys. And they will crash on it. And asthmatics do die, as noted by the CDC statistics that I posted here. Do not underestimate asthma. Okay, as soon as it stops spinning, we're going to see that the causes of acute exacerbation, 60% of it is due to bronchitis, whether that's viral or bacterial. Unfortunately, of the viral and bacterial, 60% of that, 60% viral, is more often the cause, and then bacterial bronchitis is second. So let's pick a virus, let's say the influenza virus, which ran around the whole country and started killing off people. It killed off a lot of COPDers, and it knocked off a few asthmatics. CDC predicts that 3,400 that you saw with the adults and the 200 with children is going to be much higher this year as soon as all the results are in. You'll probably be closer to 450, 500 children died. And of those, a huge number of them were asthmatic. The other children that died, of course, were immunocompromised children. Same thing with adults. They'll be kind of put in that same category where they develop a viral bronchitis, mucus production, become too much mucus, not breathing very well. And next thing you know, they go to the emergency room. Well, I just need some Tamiflu, you know, and I need an antibiotic. So they go home, and again, they're not put on the proper steroids, they're not put on oral beta agonists, syrups and such. And this is where asthmatics run into problems at home. So what stimulates these kind of asthmatic exacerbations? Well, we just talked about viral and bacterial bronchitis. So watch out for the pneumonia patient, watch out for any epidemic that goes around that has to do with influenza, and stock up on the albuterol because you're going to need it. Cold air and exertion, an asthmatic will sometimes, when they first start out with like football practice, playing tennis, you know, whatever sport that they're doing, they get short of breath. So they take a hit in the inhaler, they sit down for a second, and then the next thing you know, they're doing better, and they get back out there and they play. Same thing with cold air. When an asthmatic walks outside, they're really short of breath. That cold air just, when it gets down into those lungs, it can really cause them to bronchoconstrict. And it's not until they get warmed up and they take a hit of their albuterol inhaler do they finally start clearing up. But cold air can drop them. And if that person has also got a history of heart problems, then they pick up a snow shovel or ice pick like we had in 2010 here in Texas, and they'll get out there and they'll start shoveling. Next thing you know, they're getting short of breath, difficulty breathing, and it's their asthma. They take an albuterol hit. Next thing you know, that's already affected their heart, and they can drop from that as well. So irritants such as smoke, pollen, dust, and pets, which is always kind of an oxymoron. Let's see. I'm a smoker, and yes, doctor, yes, I do have asthma. Why do you smoke? Because I like smoking. Okay. How does that do for your asthma? It really irritates the hell out of it. I really need to get on some medications. All right, let's not talk about you going off cigarettes. It's obvious that you've gone brain dead from that. So keep going with your cigarettes while I put you on 10 different medications and anticipate 35 emergency department visits between now and the end of your life. But don't worry about that. It's not a problem. You know, just don't try and talk common sense into these people. It's not politically correct. The illicit drugs, methamphetamines is huge. Methamphetamines will lock a patient up in no time. Now, if they're smoking it or if they're inhaling it, this is where they run the problems. If they're injecting it, that's a different effect that they're having on the heart. But methamphetamine especially, or anything that's inhaled, such as cocaine, crack, and even toxic inhalants like the sniffers that were doing paint cans and such, trying to get the tetrahydrochloride into their system and get their little highs from that. Those toxic irritants can trigger asthma in a very malignant way as well. But the treatment, fortunately, is going to be pretty much the same. Now, what's the mechanism behind it? Is that there are mast cells. In other words, part of the immunological defense system of the lungs has to do with IgA, which is an immunoglobulin, but it also has these cells called mast cells, and histamine gets released as a result of these mast cells. It's a killer. It can knock out, bacteria and virus and such. Unfortunately, histamine is a very powerful bronchoconstrictor. And subsequently, allergic reactions is what trigger these. When those mast cells become really sensitized to something, I inhaled dust, pollen, mold, whatever it is, hits those mast cells, releases histamine. Next thing you know, I got myself a bad asthma attack. And oh, by the way, what if I got a bee sting or got something else that I'm really allergic to? And those mast cells release histamine. Next thing you know, I've not only got histamine, which is constricting the bronchioles, but that same histamine is vasodilating the blood vessels. So what happens? I get hypoxic and I drop my blood pressure, and next thing you know, you're in anaphylaxis. And out comes the epi, and you're given 1 to 1,000 sub-Q on these people, or IM. Or for the patients that are really crashing and burning, you get the 1 to 10,000 out, and you start touching them at 0.3 cc's at a time until you get effect. I mean, these are real nasty patients to try and handle. In addition to that, though, you want to get a histamine blocker in there. What's the greatest histamine blocker of all time? Benadryl. You give Benadryl. You can give a shot of Benadryl. You can give IV push Benadryl. You can give oral Benadryl. I mean, Benadryl. And the objective is to knock down that histamine from its effects on the body. So secondarily, you get mucus production, which restricts airflow across your bronchial tree. That's that little clogging up of the tubes that I was talking about earlier, cotton balls, hair, whatever it is that inhibits your drain in your bathrooms from draining very effectively like they used to when they were brand new. You got to get out there, you got to clean out the tubes. Same thing with the lungs. You got to get in there and you got to clean out the tubes. How do you do that? Well, can't wash out 700 million alveoli per lung. So the next thing is to give them steroids, shrinks down the production of mucus, give them antibiotics, kills the bacteria that's causing the mucus, and you can reverse these effects. But it takes several days to do that. These patients will be persistent cough with wheezing, shortness of breath at rest, and when they try to get up and walk across the room, they can't. They have to sit down. These are the people that are hanging on to stuff. I mean, they're really having a struggle and a tough time. The initial treatment for these patients, just like the COPDers, run 3 of those albuterol atropine into that mask, either put it in their mouth and have them inhale it, or put it on the mask and have them hold it over their face. And for 1 hour, let them just keep breathing it in. Yeah, albuterol will get down there. It's very good about getting past the worst of the worst plugging that's in the system. And there is some systemic absorption that occurs. Subsequently, you can backdoor it and actually get some bronchial dilation as a result of the albuterol being in the bloodstream as well. Not a lot, and I wouldn't count on a whole lot of it, but you can get some effect there. The Atrovent is really cool. It's anticholinergic, acts just like atropine, and on contact, it will start shrinking down mucus. So that Atrovent is a very, very important piece of this puzzle as well. And nowhere on the National Registry exam that I see albuterol mentioned without having the Atrovent with it. We've combined them, and unless a patient has a strong allergy to Atrovent, you need to give the Atrovent with the albuterol. 3 doses over 1 hour is standard, and you want to give the methylprednisolone, the citomedrol, again for adults, 125 milligrams IV push. For children, 1 to 2 milligrams per kilogram. IV fluids. COPDers need fluids. The asthmatics definitely need fluids. And so you'd be remiss to just bringing in the stretcher and walking them out to the ambulance and then start working them in the back of the ambulance. At least get the aerosol started, get the emergency treatment started first, and then get these guys on the stretcher. You can do the line, you can do the citomedrol in the ambulance as you're en route to the hospital, and you got to hustle in with these people. But at least get those albuterol aerosols started with the Atrovent. And then watch for the side effects. Now with the albuterol, tachycardia, chest pain, and of course the altered mental status can occur. So that's going to be signaling that you're getting much worse. So the beta-2 agonists, albuterol, which is packaged as either Provento, ProAir, or Ventolin. Xopenex. We use Xopenex, and some of your EMS systems may carry Xopenex, and I mention it only for sake of completeness for your EMS systems. I have not seen Xopenex on any National Registry exam. But we use Xopenex in the emergency department for patients who are already tachycardic, or who will be reasonably assumed to be tachycardic, where that tachycardia is going to be very deleterious to them. So let's say you got the 60, 70, 80-year-old person sitting in there that's got heart disease. Well, what's the one thing we don't want to do? Man, don't sit there during your oral interview and I give you a scenario of an anterior septal wall MI with rails, and instead of giving the patient Lasix to get rid of your rails, you tell me you're going to give an albuterol aerosol. Well, guess what your next scenario question is going to be? Okay, now that he's in cardiac arrest, you're going to need to treat that. All right, that's exactly what we don't want to hear. If you're in congestive heart failure, you give the darn Lasix. If they're having asthma or emphysema and they're wheezing, go ahead and give the albuterol. If they're older, you probably want to carry the Xopenex. Now, if you don't carry the Xopenex, you're stuck. You have to go with the albuterol. Just make sure that in the older patient, you got an EKG that's sitting there that says, I'm not having an MI with it. Okay. So a lot of stuff to this paramedic paramedic gig. There's a lot to learn out there, and there's a lot that you have to know. This is one of them, how to put it all together. Okay, so I already know about the bronchodilation effect of Proventil and Ventolin, the so-called albuterol. Now we're going to talk a little bit about the epitropium. There was one question on the most recent exam about epitropium all by itself. It has anti-secretory properties and inhibits secretions from serous and seromucous glands. Go figure. It's a very fancy way of saying I'm acting just like atropine does. I'm going to dry up the mucus. And by doing that, I'm going to open up the inside lining of the bronchioles and the bronchus and bronchioles. I'm going to open up the inside lining so I can get more air down. And as the albuterol continues, it'll open up the airways in a bronchodilation manner. And so now I've taken care of both the mucus as well as the albuterol. Now, let's say you don't have any steroids. Let's say you're in a system that does not carry steroids. You give the albuterol and Atrovent treatment, and that'll at least keep the patient stabilized enough for you to get into the hospital. Keep in mind, Solumedrol, the earlier it's given, the earlier it'll work. So if you're 30, 45 minutes away from the hospital, giving it to them means 30 or 45 minutes sooner they'll start feeling better. But Solumedrol does not have its maximum effect for between 3 to 6 hours. So if you can't give it, you can't give it. But you're going to at least have to have the Atrovent going to keep these people from producing any more mucus immediately, and then we'll worry about the back end with the Solumedrol later. But the standard of care right now for EMS systems is an albuterol aerosol with Atrovent with Solumedrol. Keep in mind on the exam, Atrovent being asked is that second paragraph that I wrote right there. It is anti-secretory properties. Now there's 5 versions of the test that's out there. It's a 1,000-question bank that we rotate every couple of years. And each version gets a different bank of questions. So this version that's out there right now has this question on it. Whether you get the exact question or not, that I can't say because the computer does all this stuff randomly. All right, and let's see, it's described in the literature, blah, 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 approved for COPD, no kidding. So you can use Atrovent with the COPD patients as well as the asthma patients. And here's the best part. You can use Atrovent with children. Do not be afraid. If you've got a combi tube that has both albuterol and Atrovent already in it, give it. If you have to add the albuterol, you have to add the Atrovent to the albuterol, do it. The Atrovent, our studies show it's a good one. It's a lifesaver. And its onset is pretty darn quick. By the time you get them to the hospital, things are already working. Okay, so for the asthma treatment, it's going to be pretty simple. And I want you to pay attention to the adult epinephrine dosing down below. You're going to do your emotional support. You're going to remain calm. You can't be panicking worse than the patient, or else everybody's going to start panicking. Do your primary survey, do your secondary, get the oxygen, get the EKG on them for the adults. Pulse oximetry, and start with the albuterol and Atrovent aerosols. If you feel like the patient's not responding, or if you get on the scene, you find that their asthma is very severe, this is the dose. And you're going to have to memorize it, not only for your skill station, but for the exam as well. So on the written exam, it's the way that it's stated for adults and pediatrics. For your skill station, you're going to have to tell the National Registry Examiner, for this 65-year-old male who's got a history of asthma, I'm going to give epinephrine subcutaneous, 1 to 1,000s, 0.3 to 0.5 milligrams or milliliters, because it's a 1-to-1 ratio. I'm going to give that for this patient. If it's a pediatric patient who your scenario will be severe asthma or anaphylaxis from a bee sting, So you got your little 5-year-old who's got stung by a bee, he doesn't have his EpiPen, and you're going to come up. What are you going to give him? Well, they give you the weight of the child at 20 kilos. So what are you going to give? 0.2. So, and you go up to 0.3. Most of the time, if you want to make it easy on yourself, you eyeball the kid. If they're small, give them 0.15. If they're big, give them 0.3. Do not go above 0.3 for a pediatric patient. Adults, go up to 0.5, and that's it. That's the ballgame. So hopefully in that period of time, and the epinephrine will last at least 20, 25 minutes before we have to redose them. But hopefully by that time, your lights and sirens are on and you're already at the hospital. So know the dosages and make sure you put 1 to 1,000. The only time you give 1 to 10,000 is through an IV. If you give 1 to 1,000 IV, you kill the patient. Okay, that's 10 times stronger than what's supposed to be given. And that kind of epinephrine is just going to send the heart right into fibrillation. So it's a 1 to 1,000, and don't give it IV push. Never. Okay, and then again, the emergent administration of methylprednisolone, which is Solu-Medrol. Again, we're trying to reduce the secretions that are being produced by the lung, and asthmatics get themselves into trouble when they're mostly dehydrated. They cannot mobilize their secretions. In other words, they can't cough them out. The infection is overwhelming for them, the pneumonia, the bronchitis, whatever it is, too much mucus. Solu-Medrol is going to knock that down pretty quick. Again, 2 to 6 hours, 3 to 6 hours. You know, the earliest I've ever seen Solu-Medrol work is 2 hours, where it's really shown a clinical effect on the patient's breathing. And it does peak at 6 hours, and it lasts, you know, for a few hours after that. We have to keep redosing it. Prednisone, on the other hand, is a good 24-hour med. And when you're giving that stuff oral, although it takes almost 6 hours for it to really kick in and make you feel better, well, I'll tell you, once that PO prednisone, that oral prednisone kicks in, man, the asthmatics feel like $1 million because it takes care of all the mucus. And all you got to do is worry about the bronchodilation at that time. So you'll find that patients who are on prednisone, if they're COPD or asthma, when you're doing your history and physical, your sample history, and you're asking about meds, have they ever been on steroids? That's huge. Okay, is there any questions about today? We've gone about an hour now. We're at the 1 hour mark. Next week, I'm going to start on status asthmaticus, and then we're going to go through the rest of the slides that have to deal with toxic inhalations and pneumonias and such, things that you have to know, especially for the sepsis side of it. And again, these slides, I just made them up not even a week ago. Because I did view that paramedic exam, and I'm just like, you know what, we're missing some things on these exams that we really need to be re-emphasizing with you good folks. So, all right, I'm going to open up the chat here real quick, and let's see what we. You have a question about albuterol, Will? You go right ahead. What you got?
Yeah, I was just curious. In the agency that I work for, we carry normal saline for inhalation along with our albuterol. And I was just curious what the added benefits of mixing it when giving the treatment was.
The beauty of whenever you add salt to any kind of fluid and you put it on mucus, it breaks up the mucus. It is tremendous in breaking up mucus. A person can spit up really hard, dry mucus. I get it out on a piece of cloth. I put normal saline on it, and the mucus virtually turns into a thin liquid. The salt creates it. In other words, crenate means that it draws the water out of the cells and out of the mucus, and it collapses the cells on themselves. And so it is great for busting up mucus. You'll find out that we'll squirt saline down an ET tube and then drop the deep suction down and then suction back up again. That's breaks up mucus about as good as anything I've ever seen.
Okay. Thank you.
No, no problem. Okay, Seth, good question. Good statement. Yeah, EtCO2 has become the standard of care. When you do end-tidal CO2 on patients, it's the first best way to decide whether or not your patient's going to respiratory failure. Look, stage 3 asthma is the same as stage 3 COPD. CO2 is on the rise, but the oxygen is still kind of sort of normal. Stage 4 is when they both crash, when the patient becomes hypoxemic in stage 4 asthma or stage 4 emphysema. If there is a way, if there's ever been a role of the paramedic, the most important role a paramedic can do when they have the opportunity, it's to intervene before the patient circles the drain. And believe me, when you're at stage 3 asthma or stage 3 COPD, you are circling the drain big time. And subsequently, knowing that that CO2 is on the rise, and yet they haven't dropped their oxygen yet, this is a great opportunity for you to slam them with the steroids, hit them with the albuterol and Atrovent, hustle them into the hospital. When they hit stage 4, I tube them. There's no doubt about it, no questions asked. If you're hypoxic, I know you've gone through stage 1, 2, and 3, and your CO2 is already building, you're going to die. And so you're going to get a tube as soon as you start showing that hypoxemia. Okay, now I get to Scott, and I'll say, well, next week's session be? Whenever you want it, Scott, we've left this one open to you. You just name the time and place. 2 o'clock in the morning is great. I'm up. Elise, for someone that has COPD, said O2 wouldn't hurt if their SpO2 is low, but their SpO2 is 98% or more, but they're still having difficulty breathing. Will O2 hurt? Yes, it will, because you're not going to get any more improvement. Once you're over 95%, there's studies out there that say you don't even need oxygen applied to you, even heart attack patients. We put oxygen on heart attack patients to get them from 95 to 100%, hoping that that extra oxygen gets into the collaterals and keeps the area of the heart damage limited. Same thing with the brain when they're having a stroke, but our studies have not shown that. It's what we call a feel-good myth. In other words, geez, 95 is good, 100% has to be better. And yet there's been no studies that have shown that anything above 95% gives any extra benefit to anybody with supplemental oxygen. Your most important factor at this point is if your COPD patient lives around a PCO2 of 55 to 65, well, you know, that end-tidal CO2 is going to be beneficial, because you'll say, okay, you're usually at 65, now you're at 80. I can expect you to die very shortly. I'm going to watch for your hypoxemia. I may put them on a little bit more oxygen to prevent stage 4 from hitting until I can get them to the ER. Okay. All right, now, yes, and you're right, Elise, it's the long-term people that really have to worry about. And it's the nursing homes. And remember the purpose of the nursing home, which is essentially death watch facilities. Their job is to try to keep the patient as comfortable as they can for as long a period as they can for the remainder of the patient's life. Sometimes they inadvertently expedite that. And the best way to do that with a COPD, they see that they're having a shortness of breath, so they'll dial them up to 5 or 6 liters, and they'll check back on you an hour, you know, and then 4 hours later, which is a typical nursing home 1 hour, the patient's no longer with us. So you have to watch for that as well. It doesn't mean you challenge them, doesn't mean you confront the nursing home with their screw up or anything like that. It just means be aware that this is probably what's happened. You're going to have to take drastic measures. Okay. And putting somebody on a bag valve mask and bagging them without oxygen hooked up to it, just using the good old 21% that's around the atmosphere, works perfectly fine. Okay, for some, let's see, typically O2 on her, somebody care, it's really a bigger deal when patients go long-term care. Absolutely. Absolutely. Where'd my mouse go? There we go. Okay, thanks. I'm here to say anyone under 97%, you should put O2 on. I'll wait for 94 or less. Yep. Elise, that's exactly right. So to confirm, we will see a change in CO2 even when the patient is compensating. Must have missed the stages. You know, this actually the stages that I gave you is something that as you transition from student paramedic to field paramedic, and then from field paramedic to ER tech, critical care paramedic, nurse, physician. Okay, to know the stages, the more you know, the more you know. And so if you see a person who's got a high oxygen, you know, an asthmatic sitting in the corner breathing 30 times a minute, his CO2 is low. Well, hell, he's blowing off CO2. What does that mean? He's probably more hyperventilating than anything. He's in stage 1 asthma. I just put an albuterol aerosol and take him to the hospital. Nothing to worry about. Stage 2. I want you to think about this very carefully, guys. If I'm sitting in the corner and I have normal lungs and I sit there and I hyperventilate and I breathe at 30 times a minute for 30 minutes, and then you take a blood gas on me, what should you find with my CO2? Anybody got an answer for me? What happens with normal lungs when you hyperventilate a patient is that they blow off CO2. And by blowing off CO2, it'll get down into, instead of being 35 to 45, it'll be 30, 25, and something like that. And that's a normal functioning lung. Now, you take that same person breathing 30 times a minute, but he's an asthmatic having an asthma attack, and you check his end-tidal CO2, and he's actually 35, 38, maybe 40. You're going to go, oh, well, that's normal. Is it really normal? This is a case where normal is not normal, because we've already talked about that a normal lung sitting in a corner breathing 30 times a minute should blow off CO2. Their CO2 should be 25 to 30, and yet in this particular case, they're 38, 40. In other words, they've had their time where they've already blown off the CO2. Now they can't do it as well anymore, and so now it's building back up. And you just happen to catch them at a time where that CO2 is traversing through the normal range. Do not interpret that as normal. Look, if they're breathing at 18 times a minute and they've got that, they're not having much in the way of shortness of breath, that's fine. But if they're 30 times a minute and saying, I'm really short of breath and I'm wheezing, and their CO2 is normal, it's not normal. That's stage 2 asthma. Stage 3 asthma, just an extension of stage 2. Now the CO2 is above normal. It's above 45. But the patient is not hypoxemic. Stage 4 is when the patient goes hypoxemic with the high CO2. So knowing where your end-tidal CO2 is at is going to give you a very good idea where your COPD and asthmatic patients are, and you can treat accordingly. So to confirm, we'll see a change in CO2 when the patient's compensating. Yes. I suppose it all goes back to treat the patient, not the numbers. Absolutely, Denver. In my area, we don't give O2 until the patient's less than 94 and less than 90 for COPD. That's reasonable. I mean, I can't set absolute numbers like Denver just said. I wouldn't look at the numbers as much as I look at the patient. I'll have the monitor in the background, but I'm usually standing next to the patient, not the opposite. I don't stand next to the monitor to determine what the patient is going to do. I stand next to the patient to see what I'm going to do for the patient. And I think that that should be your underlying approach to any patient is how does he look? How does he feel? Do the numbers match up? You'll compare the numbers, but very rarely do I make treatment decisions based on numbers that I'm seeing. Load and go. And that's probably not a bad way to go. Back in the 70s when I first started out as an EMT, they were all Cadillac and Oldsmobile ambulances, man. They were all, designed to go 100 miles per hour. So you loaded them and you took off. More survivability because the paramedics are getting on a scene and they're spent a lot of time treating and getting histories and physicals, hooking up the monitors, calling the hospital. Then they were loading and they were going. And then we saw, especially with the trauma back when shock trauma did their big traumas in the late 70s, early 80s, they said, no, they can't do that anymore. So load and go is not a bad strategy. All right, I think we're going to end it here. Save your questions for next week. I hope to see you all next week. Jane will put out an announcement as to when we will meet again. And I look forward to seeing you guys for part 2 of respiratory emergencies. Y'all have a great night.
Dr. Frame, can you hear me?
Yep. Yes, I can.
When did you say we were going to meet again so I can set it up? When did you say we were going to meet again so I can set it up?
Yeah, let's see. I work Tuesday, Wednesday, Thursday, work Friday. How about next Monday?
Monday, let me see, make sure I get the right date. Monday evening on Monday the 16th?
Wait a minute. No, it can't be Monday. How's Tuesday, the 17th? Or we
Tuesday
can do
the
it,
17th.
or we can do it Sunday
All
the
right,
5th, or we can do it Sunday the 15th.
I'll set it up. Huh?
Well, you may want to poll all the guys. So I'm 15 or 17.
I think
either one.
Tuesday
Go
the
ahead.
17th is probably more palatable.
All right, sounds good to me. All right, everybody, see you on the 17th. Bye.
Thank you. Good night.